Student, today's topic is uterine sarcoma. 1% of all female genital tract malignancies are uterine sarcomas. 3 to 7% of all uterine cancer are uterine sarcomas. Histologically, carcinosarcomas, which is now recently moved to endometrial carcinoma. One is leiomyosarcomas or endometrial stromal sarcoma, which can be of low grade or high grade endometrial stromal sarcoma or undifferentiated sarcoma. Another is adenosarcoma, carcinosarcoma. It has been reclassified based on its spreading pattern. That is, it has been removed from uterine sarcoma to endometrial carcinoma. More aggressive than usual type of endometrial carcinoma, carcinosarcoma is still included in most retrospective studies of uterine sarcomas, as well as in the separate section of mixed epithelial and mesenchymal tumors of 2014 WHO classification. But it has been updated. Now it has been reclassified into endometrial carcinoma. Tumor stage is the single most important prognostic factor. New staging system, two division. One is leiomyosarcoma, another is endometrial stromal sarcoma, along with adenosarcoma. And carcinosarcoma is now staged according to endometrial carcinoma. Risk factor of uterine sarcoma: prolonged use of tamoxifen, a uterine estrogen receptor agonist, associated with 3 times risk of sarcoma development. There has been reported cases of radiation-induced sarcomas occurring long after treatment of other cancer. So tamoxifen and radiation are risk factors. Pre-op imaging is of no use. Neither with ultrasound or PET scan is capable of differentiating between a benign or malignant smooth muscle masses. But the use of diffusion-weighted magnetic resonance imaging for tumor location and characterization has been suggested, but yet to be validated. Patients with carcinosarcomas and adenosarcomas tend to be in a much older patient than patient with other sarcomas. First is leiomyosarcoma, which is second most common after carcinosarcoma. But carcinosarcoma is included in endometrial carcinoma. So leiomyosarcoma is the most common type of sarcoma now. Only 1 to 2% of uterine malignancies, 1 in every 800 smooth muscle tumor of uterus is leiomyosarcoma. Over 40 years of age usually seen. Present with abnormal vaginal bleeding, a palpable pelvic mass or pelvic pain. Signs and symptoms resemble those of the far more common leiomyoma, and preoperative distinction between these tumors may be difficult. Malignancy should be suspected by the presence of tumor growth in postmenopausal women who are not using hormone replacement therapy, although it is rare for leiomyosarcoma to present as a rapidly growing tumor. So phygostaging for uterine sarcoma: leiomyosarcoma and ESS, endometrial stromal sarcoma, phygostaging is different, whereas adenosarcoma phygostaging is different, and carcinosarcoma staging should be based on carcinoma of the endometrium. Stage 1: tumor limited to uterus. 1A is less than 5 cm size tumor, 1B more than 5 cm size tumor. 2 is beyond the uterus but within the pelvis. 2A is adnexal involvement and 2B is other pelvic tissue involvement. 3 is tumor invades abdominal tissues, not just protruding into abdomen, that is not protrusion but invasion. If one side, then 3A, more than one side, 3B. 3C is lymph node, pelvic or paraortic lymph node. 4A is tumor invades bladder or rectum. 4B is distant metastasis. In adenosarcoma, stage 1 is divided into 3, 1A, 1B, 1C. But stage 1 is limited to uterus. 1A is limited to endometrium or endocervix with no myometrial invasion. 1B is less than or equal to half myometrial invasion. 1C is more than half myometrial invasion. Along with stage 2, 3 and 4 are same as leiomyosarcoma. Pathological features of leiomyosarcoma: either single masses or when associated with leiomyomas, the largest mass. Voluminous tumor with a mean diameter of 10 cm. Only 25% of cases measure less than 5 cm. So approximately 10 cm size of mass. And cord surface is soft, bulging, fleshy, necrotic, hemorrhagic, and lacks the prominent hold appearance of leiomyoma. There is no hold appearance in leiomyosarcoma, whereas there is hold appearance in leiomyomas. Necrotic, hemorrhagic, these areas are present in leiomyosarcoma, whereas it is absent in endometrial stromal sarcoma. Histopathologic diagnosis: hypercellularity, there is increased cellularity, severe nuclear atypia, high mitotic rate exceeding 15 mitotic figures per 10 high power fields, that is high mitotic rate. This is a histopathologic picture of leiomyosarcoma: increased cellularity, increased nuclear atypia, and increased mitotic figure. Moreover, one or more supportive clinicopathologic features such as peri or postmenopausal age, extrauterine extension, large size tumor that is more than 10 cm, infiltrating border, necrosis, atypical mitotic figure. These pictures shows leiomyosarcoma. Two rare variants, difficult to recognize microscopically. Pathologic features differ from those of ordinary spindle cell leiomyosarcomas. Nuclear atypia is usually mild and the mitotic rate often less than 3 mitotic figure per 10 high power field. There is infiltrative borders. Necrosis may be absent in epithelioid leiomyosarcomas, whereas mixed leiomyosarcomas are often hypocellular. So three types of leiomyosarcoma. One is ordinary spindle cell leiomyosarcoma, one is epithelioid and mixed. Epithelioid and mixed are rare variants, whereas those we discussed in previous slide are typical picture of spindle cell leiomyosarcoma. These pictures are seen in epithelioid and mixed. Necrosis absent in epithelioid. Mixed are hypocellular. Leiomyoma variants that may mimic malignancy: mitotically active leiomyoma, cellular leiomyoma, hemorrhagic leiomyoma, and hormone-induced changes, leiomyoma with bizarre nuclei, myxoid leiomyoma, epithelioid leiomyoma, leiomyoma with massive lymphoid infiltration, smooth muscle proliferations with unusual growth patterns, disseminated peritoneal leiomyomatosis, benign metastasizing leiomyoma, intravenous leiomyomatosis, lymphangioliomyomatosis. Those are unusual growth pattern of leiomyoma. Stump or atypical smooth muscle tumor. Smooth muscle tumor of uncertain malignant potential. Tumor cell necrosis in a typical leiomyoma. Necrosis of uncertain type with more than or equal to 10 mitotic figure per 10 high power field, or marked diffuse atypia. Marked diffuse or focal atypia with borderline mitotic counts. Necrosis difficult to classify. So these picture diagnosis of stump. Immunohistochemistry and molecular biology of leiomyosarcoma. Smooth muscle marker such as desmin, aldesmin, smooth muscle actin, histone deacetylase 8. However, epithelioid and myxoid variants of leiomyosarcoma may show a lesser degree of immunoreaction for these markers. Leiomyosarcoma are often immunoreactive for CD10, mainly marker of endometrial stromal differentiation. CD10 is a marker of endometrial stromal differentiation. And epithelial markers including keratin and EMA. EMA is more seen in epithelioid variant. Conventional leiomyosarcoma express estrogen receptor, progesterone receptor, and androgen receptor in 30 to 40% cases. The level of Ki67 are higher in uterine leiomyosarcomas compared with benign smooth muscle tumor, that is fibroid. Overexpression of P16 has been described in uterine leiomyosarcomas and may prove to be useful adjunct immunomarker for distinguishing between benign and malignant uterine smooth muscle tumor. The vast majority of uterine leiomyosarcomas are sporadic, whereas patients with germline mutations in the fumarate hydratase are believed to be at increasing risk for developing uterine leiomyosarcomas as well as uterine leiomyomas. Prognosis of leiomyosarcomas associated with poor prognosis, even when confined to the uterus at the time of diagnosis. Recurrence rate is around 53 to 71%. Fast recurrence occur in lungs. Most common site is the lungs in 40% of patients, and in the pelvis only 13%. So most common site of recurrence is lungs. Overall 5-year survival rate ranges from 15 to 25%, with a median survival of only 10 months in one study. All patients with tumor spread outside the pelvis died within 5 years. So it shows a poor prognosis. Predictive of prognosis: size of tumor, grade and stage of tumor, mitotic index, parameters including P53, P16, Ki67, BCL2 has been used to predict the outcome in leiomyosarcomas. Tumor greater than or equal to 10 cm in diameter with greater than or equal to 20 mitotic figure per 10 high power field, greater than or equal to 10% immunoreactive nuclei for Ki67, and negative for BCL2, had worse prognosis than smaller leiomyosarcomas with less than or equal to 20 mitotic figure, less than 10% immunoreactive nuclei for Ki67, and positive or negative for BCL2. So this is the poor prognostic marker. Treatment: total abdominal hysterectomy and debulking of the tumor if present outside the uterus. So total abdominal hysterectomy is the preferred treatment. Removal of the ovaries and lymph node dissection remain controversial, as metastasis to this organ occurs in only a small percentage of cases and are frequently associated with intra-abdominal disease. Ovarian preservation may be considered in premenopausal patients with early stage leiomyosarcomas, but you have to do TAH. There is no conservation of uterus. Lymph node metastases have been identified in 6.6% and 11% in two series of patients with leiomyosarcoma who underwent lymphadenectomy. In the past, hyper disease specific survival rate was 26% in patients who had positive lymph node, compared with 64% in patients who had negative lymph node. So positive lymph node gives poor prognosis. In completely resected organ confined disease, that is stage 1 or 2, the influence of adjuvant systemic therapy or radiotherapy on survival is uncertain. Docetaxel or gemcitabine, doxorubicin, and ifosfamide all are reasonable options for advanced or recurrent disease with low response rate, that is of 17 to 36% only. Some tumors may respond to hormonal treatment, and targeted therapy such as trabectedin, olaratumab have been investigated as treatment in advanced stage or metastatic leiomyosarcoma with some appreciable disease control. So STOMP, atypical smooth muscle tumor, uterine smooth muscle tumor that shows some worrisome histologic picture, that is necrosis, nuclear atypia or mitosis, but do not meet all those diagnostic criteria for leiomyosarcoma, fall into the category of atypical smooth muscle tumor of STOMP. There is necrosis, there is atypia, there is mitosis, but in less number. In high number, it diagnoses leiomyosarcoma. In less number, it is diagnosed as STOMP. This diagnosis, however, should be used sparingly, and every effort should be made to classify a smooth muscle tumor into a specific category when possible, whether it is benign or malignant. Most tumors classified as STOMP have been associated with favorable prognosis, and in these cases, only follow-up of patient is recommended. There is no need to give any adjuvant treatment. Endometrial stromal tumor. It is less than 1% of all uterine tumor. It represents second most common category of mesenchymal uterine tumor after leiomyosarcoma, predominantly or exclusively intramural neoplasm, divided into benign and malignant based on type of tumor origin. Well circumscribed tumor are benign stromal nodule. That is, endometrial stromal tumor can be of benign or malignant. In benign, it is benign stromal nodule and exhibiting myometrial invasion and permeation of myometrial lymphovascular spaces are sarcoma. So those shows myometrial invasion and myometrial lymphovascular spaces invasion, it is sarcoma. Endometrial sarcoma are further classified by the WHO classification based on how closely the tumor resembles proliferative type of endometrial stromal. One is low grade endometrial stromal sarcoma, one is high grade, and other is undifferentiated endometrial sarcoma. First is low grade endometrial stromal sarcoma. Between 40 to 50 years of age, more than 50% are premenopausal. Risk factor are PCOD after estrogen use or tamoxifen therapy. It present with AUB, pelvic pain and dysmenorrhea, but as many as 25% are asymptomatic also. At present, extrauterine pelvic extension, most commonly involving the ovary, is found in up to 1/3 of patients. Whereas in leiomyosarcoma, you can think of conserve ovary, but in low grade endometrial stromal sarcoma, don't think to conserve ovary because there is extension to the ovary. Microscopically, endometrial stromal sarcoma consists of well differentiated endometrial stromal cells exhibiting only mild nuclear atypia and characteristically invade the LVSI of myometrium. Tumor cell necrosis is rarely seen in low grade, whereas tumor cell necrosis is predominantly seen in LMS. The tumor cells are strongly immunoreactive for CD10, usually positive for smooth muscle actin and less frequently desmin, but they are negative for caldesmin and HDAC8, which is present in leiomyosarcoma. Estrogen receptor only alpha isoform progesterone receptor, androgen receptor, and WT1 are typically positive, whereas this is 30 to 40% positive in leiomyosarcoma. Nuclear beta-catenin expression has been shown in up to 40% of low-grade endometrial stromal sarcoma. Most common cytogenetically abnormality is the recurrent translocation involving chromosome 7 and 17, translocation 7 and 17 and P15Q21, which results in a fusion between JAS-F1 and SUS12, formerly designated as JAS1. Fusion can be detected by FISH, also RT-PCR. Indolent tumors with a favorable prognosis is low-grade endometrial stromal sarcoma. Late recurrence even in patients with stage 1 disease, thus long-term follow-up is required. About 1/3 of patients develop recurrence. Most common site is the pelvis and abdomen, less frequently in the lungs and vagina, whereas lungs is more commonly involved in LMS. Stage of the tumor is the most significant prognostic factor. Surgical stage higher than stage 1 is a univariate predictor of unfavorable outcome. 5-year survival for patient with stage 1-2 tumor is 90%, whereas higher stage is around 50%. Treatment is mainly surgical in the form of hysterectomy and bilateral salpingo-oophorectomy. You cannot think of conserving ovary in low grade. Tumors are often sensitive to hormones. Patients with retaining their ovaries have a much higher risk of recurrence, up to 100%. Lymph node dissection does not seem to have a role in treatment of this tumor. Patient may also receive adjuvant radiation or hormonal treatment with a progestational agent or aromatase inhibitor. Post-treatment hormone, that is estrogen replacement therapy, is discouraged. High-grade endometrial stromal sarcoma. These rare tumors have features that are intermediate between low-grade endometrial stromal sarcoma and undifferentiated stromal sarcoma. So this is in between low-grade and undifferentiated sarcoma. Patient range in the age group of 28 to 67 years and mean is the 50 year. Present with vaginal bleeding, enlarged uterus or pelvic mass. Tumor may appear as a intracavitary polypoid or mural masses. Size up to 9 cm and median size is 7.5 cm. Often shows extrauterine extension at the time of diagnosis. Cord surface is fleshy with extensive area of necrosis and hemorrhage. Microscopically, they consist predominantly of high-grade round cells that are sometimes associated with low-grade spindle cell component, that is most commonly fibromyxoid. Mitotic activity is striking and typically greater than 10 per 10 high power field. Necrosis is usually present. Rarely areas of conventional low-grade endometrial stromal sarcoma are also seen. High-grade are negative for CD10, estrogen receptor and progesterone receptor, but positive for cyclin D1 immunoreactivity. They are also typically c-KIT positive but DOG1 negative. High-grade typically harbors the YWHAE and FAM22 genetic fusion as a result of translocation between 10 and 17, whereas 7 and 17 translocation is seen in low grade. This is a picture of high-grade endometrial stromal sarcoma where necrosis is present, mitotic activity is high, around 10 mitotic field in 10 high power field, tongue-like infiltration and LBSI are present. Rarely areas of conventional low-grade sarcoma are also seen. These tumors appear to have a prognostic that is intermediate between low-grade and undifferentiated. Compared with low-grade, patients with high-grade R have earlier and more frequent recurrences, often less than 1 year for recurrence, and are more likely to die of that disease. Advanced or recurrent tumors should be treated aggressively with a combination of radiation and chemotherapy, as they do not respond to conventional treatment of low-grade sarcomas. Undifferentiated. These tumors are rare and typically present in postmenopausal lady. Mean age is 60 years and have complaint of postmenopausal bleeding or sign or symptoms secondary to extrauterine spread. Approximately 60% of patients present with high-stage disease, that is stage 3 or 4. The diagnosis of undifferentiated sarcoma is applied to tumors that exhibit myometal invasion, severe nuclear pleomorphism, high mitotic activity, tumor cell necrosis, lack of smooth muscle or endometrial stromal differentiation. The histological appearance of the tumor is more like the mesenchymal elements of a carcinosarcoma than a typical endometrial stromal tumor. It is variably CD10 positive and typically ER and PR weakly positive or negative. Undifferentiated are highly aggressive tumors that are associated with very poor prognosis, less than 2 years survival. Patients should be treated by hysterectomy and bilateral salpingo-oophorectomy and adjuvant radiation and or chemotherapy. Adenosarcoma. Mullerian adenosarcoma is a mixed tumor of low malignant potential that shows an intimate admixture of benign glandular epithelium and low-grade sarcoma, usually of endometrial stromal type. It represents between 5 to 10% of uterine sarcoma, mainly in uterus of postmenopausal lady in 58 years, but also seen in adolescent and young adults around 30%. Most adenosarcoma arise from the endometrium, including the lower uterine segment, but rare tumors develop in the endocervix 5 to 10% of cases and in extrauterine locations. Adenosarcoma are polypoid tumors of approximately 5 to 6 cm in maximum diameter. Range can be 1 to 20 cm that typically fill and distend the uterine cavity. Adenosarcomas with sarcomatous overgrowth tend to be larger with a fleshy, hemorrhagic and necrotic cord surface. They invade the myometrium more often than conventional adenosarcoma. So adenosarcoma are two types. That is conventional adenosarcoma. Another is adenosarcoma with sarcomatous overgrowth. So with sarcomatous overgrowth having poor prognosis with necrosis and hemorrhagic cord surface area. Microscopically, the stroma typically concentrates around the glands, forming a periglandular corpse. Well-differentiated tumor may exhibit only mild nuclear atypia and very few or no mitosis in the stromal component. However, the presence of hypercellular periglandular corpse helps to distinguish adenosarcoma from its rare benign counterpart, that is adenofibroma. Adenofibroma is the benign one where there is no periglandular corpse, whereas adenosarcoma having the periglandular curve. This is the picture of adenosarcoma having periglandular curve. Heterologous mesenchymal elements, usually rhabdomyosarcoma, are found in 10 to 15% of cases. Vaginal or pelvic recurrence occur in approximately 25 to 30% of cases at 5 years and is associated almost exclusively with a myometrial invasion and sarcomatous overgrowth. Myometrial invasion is found in approximately 15% cases, but deep invasion is only of 5%. Sarcomatous overgrowth, defined as the presence of pure sarcomas, usually of high grade and without a glandular component, occupying at least 25% of the tumor, has been reported in 8 to 15% of uterine adenosarcoma. Whereas immunoreactions for cell proliferation marker like Ki67, P53 are stronger in adenosarcoma with sarcomatous overgrowth than typical adenosarcoma. The expression of marker of cell differentiation, that is CD10 and PR, is higher in typical adenosarcoma than in adenosarcoma with sarcomatous overgrowth. So typical adenosarcoma having expression of marker of cell differentiation, whereas adenosarcoma with sarcomatous overgrowth having increased cell proliferation marker. Except when associated with myometrial invasion or sarcomatous overgrowth, the prognosis of adenosarcoma is far more favorable than that of carcinosarcoma. However, about 25% with adenocarcinoma ultimately die of their disease. Recurrences are usually composed exclusively of mesenchymal elements. Distant metastases, which occur in 5% cases, are always composed of pure sarcoma. The treatment of choice is TH, total abdominal hysterectomy with bilateral salpingo-oophorectomy. Carcinosarcoma, also referred as malignant Mullerian mixed tumor. It is a biphasic neoplasm composed of distinctive and separate but admixed malignant appearing epithelial and mesenchymal element. Mean age is 7th decade, but the age can range from 4th decade to 9th decade. Typically present like endometrial cancer of vaginal bleeding. Another presentation is a polypoid mass that protrudes through cervical os. The epithelial component is of serous or high-grade carcinoma, not otherwise specified, in about 2/3 of cases, and endometrial carcinoma in approximately 1/3 cases. In a recent study, 10% of the carcinomatous component are FIGO grade 1, 10% grade 2, whereas high grade, that is grade 3, is seen in 80% cases. The homologous component of carcinosarcoma are usually spindle cell sarcoma without obvious differentiation. It mainly resembles fibrosarcoma or pleomorphic sarcoma. Almost all are high grade sarcomas. The most common heterologous elements are malignant cartilage or skeletal muscle, constituting something that resembles either pleomorphic rhabdomyosarcoma or embryonal rhabdomyosarcoma. Carcinosarcoma are highly aggressive tumor, far more aggressive than usual endometrial carcinoma. The overall 5-year survival for patient with carcinosarcoma is around 30%, and for those with stage 1 disease is approximately 50%. This is in contrast with other high-grade endometrial cancers, for which 5-year survival in stage 1 disease approximately 80% or higher. As a result of its aggressive behavior, adjuvant systemic therapy consists of ifosfamide, Taxol, and platinum agent is routinely given even when the disease in its early stage. Adjuvant radiotherapy is also commonly utilized. In carcinosarcomas, there is general agreement that surgical stage is the most important predictor regardless of how the patient was staged. One study found that the presence of a heterologous element is a poor prognostic factor in patients with FIGO stage 1 tumor. Other factors proposed include the histology grade of the carcinomatous and sarcomatous element, the percentage of tumor with sarcomatous differentiation, depth of myometrial invasion, and the presence of lymphovascular space invasion. Treatment of carcinosarcoma. Primary surgery for early disease includes hysterectomy, bilateral salpingo-oophorectomy, and pelvic node dissection, as the tumor spread pattern is similar to high-grade endometrial carcinoma. Omentectomy is also advocated by some. Complete cytoreduction should be aim of the surgery, as this may be associated with an overall survival benefit. Combination chemotherapy seems to result in a fewer recurrence than whole body irradiation. Patients with carcinosarcoma, however, tend to be elderly with comorbidities. The ideal agent still need to be established. The results of GOG study 261 aims to compare ifosfamide or paclitaxel versus paclicarbo combinations in patients with advanced stage or recurrent carcinosarcoma are awaited. Radiotherapy is only able to control the pelvic disease. This is the picture of carcinosarcoma. Follow-up of sarcomas. Follow-up should be determined by the risk of recurrence. As metastasis to lung is common, effort must be made to rule out these, remembering that early lesions tend to be asymptomatic but resectable. Low-grade sarcoma patients may be followed for local relapse every 4 to 6 months for the first 3 to 5 years, then yearly. The high-grade tumors can be followed up every 3 to 4 months for the first 2 to 3 years, a year for the next 2 to 3 years, and then annually.